Hello, you're listening to the RxConnect podcast. This podcast is brought to you by the pharmacy operations at the American Oncology Network. We are committed to delivering operational, clinical, and financial efficiencies based on the most sustainable model, reshaping the future of community oncology practice. I am your host, Melody Chang, VP of Pharmacy Operations at the American Oncology Network. On today's episode, we are going to talk about bispecific T-cell engaging therapies in community oncology. We know immunotherapy and cellular therapy has revolutionized the treatment of cancer. And most patients with cancer in the United States are treated in the community. So we have privilege to invite our special guest today, experts on this area, to talk about how community oncology practice are using the bispecific. To listen to the podcast and to read the transcript, please visit our website at www.aoncology.com. I'm delighted to introduce our guest speakers, Dr. Birhiray. He's a Hematology Oncology of Indiana. He completed fellowships in bone marrow transplant and medical oncology at Johns Hopkins University and the National Cancer Institute in Bethesda, Maryland. Dr. Birhiray has participated in research and has published on the subjects of immunotherapy, lymphomas, and bone marrow transplants. We also have our special guest, our clinical pharmacist from American Oncology Network, Perkey and Brooke Peters. Welcome, Dr. Birhiray, and welcome, Cassie. Welcome, Brooke.
Thank you so much for inviting us.
Sure. Dr. Birhiray, for the benefit of our audience, could you educate us what is bispecific therapy? Is there any difference between bispecific versus CAR-T therapy or transplant?
Yes, that's actually a commonly asked question, Melody, and so I'm glad you asked the question. So the way to think about it is that bispecific therapy is a way of engaging the immune system of the patient to treat cancer. And the way you do it is that you essentially bring the patient's immune T cells close in proximity to the cancer cells so that they can kill the cancer cells. So if you will, it's like an immune engagement product. And essentially, it's almost as though you are a matchmaker for the immune system. So just like the word bispecific, which means it has two things, it has two arms. Mm-hmm. One arm grabs the T cells, which are part of the immune system of the patient. Mm-hmm. They are circulating in the blood. And the other arm grabs the cancer cells and it brings them together. So there are a number of bispecifics now available for the treatment of blood cancers and also some solid tumors. But essentially, that's the principle of using an antibody that has two arms, one arm grabbing the T cells of the patient and the other arm grabbing the cancer cells. Mm-hmm. CAR-T therapy, on the other hand, is a little bit more complicated. CAR-T therapy means you take a patient's blood cells, you take their T cells, which normally are unable to attack the cancer cells, and you use a process of, sometimes we use a virus and the other strategies that are used, of inserting into those T cells an antibody receptor. And that antibody receptor is able to then recognize the cancer cells of the patient. So for example, if a patient's cancer has a protein on its surface, in the case of lymphomas that is called CD20, or CD19, for example, you could then put an antibody in the T cells of the patient, and the antibody is directed towards CD19, and that antibody is then able to kill the lymphoma cells because they express CD19. And that process means that you have to take the patient's blood, take them to a lab, and then be able to insert the antibody. And that's what CAR T therapy means, which means chimeric antibody receptor therapy. On the other hand, a stem cell transplant could be using your own blood, which is an autologous stem cell transplant, or using somebody else's blood, which is an allogeneic stem cell transplant. And essentially what you do is you take stem cells, which are very premature cells that are in the bone marrow of either the donor or the patient, and you give them to the patient after giving a very high doses of chemotherapy to try to eradicate the cancer and suppress the immune system. So really, these are all forms of immunotherapy, but they are different and they have different side effects and different complexities. So I hope that explains it.
Well, this is excellent, Dr. Birhiray, for your detailed explanations. Now, at least our audience have a basic understanding what's the difference between the bispecific and CAR T versus transplant. I know you have a lot of experience of treating patients using bispecific. Could you share with your experience what type of cancers or what type of patient selections and who will be most benefit from this bispecific treatment?
Oh, thank you. So the bispecifics have been around for a long time, although there's been a lot more buzz recently because they are now available for multiple cancers. The first one was a drug that was approved for ALL, or acute lymphoblastic leukemia, a drug called blinatumomab, which targets CD19, which is present on those cells. And then now we have them for lymphomas and also multiple myeloma. And they're typically used in the case of multiple myeloma and lymphomas for patients who have failed standard treatments. Standard treatments could be chemotherapy, standard treatments could be immunotherapy that they would have failed. And right now we are using them to treat those patients because they really do not have options. But these drugs are quite effective. In the case of multiple myeloma, in patients who would have failed at least 4 prior lines of therapy and would have failed multiple drugs that are effective in myeloma, about half of those patients will respond. And those responses can last more than a year. There are some side effects that you would expect. One of them are the so-called immune side effects, because when you engage the immune system, sometimes the immune system goes a little bit awry and it gets a little too happy, and in doing so can cause the patients to develop what we call cytokine release syndrome, which is where the immune cells, because they're so activated, they release chemicals, and those chemicals could cause fever, shortness of breath, and we have medications that we sometimes have to give to mitigate those side effects. Other side effects sometimes could be neurologic side effects, which is brain side effects, where patients could get confused or have changes in their handwriting or their gait, and sometimes we use steroids to reduce that. But they are quite effective, and that's really what we like about them. And we've had experience in using them in both lymphomas and multiple myeloma. We've been very happy with the results that we've seen so far.
Yes. Oh, thank you very much. And talking about the side effect, Kelsey, I want to ask you, or maybe Brooke, you can chime in as well. As a clinical pharmacist, I believe both of you deal with the side effect and the educations to the patients, to the staff, very, very much on a daily basis. Would you be able to share with us how do you do the educational piece and how do you manage the side effect that because the treatment of bispecific?
Yes, of course. Thanks for this question, Melody. So in regards to education, pharmacists like myself and Brooke were usually involved in, upfront coordinating cellular therapy initiation with communicating between the provider, nurse manager, financial team, sometimes hospital staff. And we often will engage our pharma partners to help with providing staff education on the cellular therapy products prior to initiation. And then we're always available then to support with that education and for side effect management as the patients are getting started on therapy. Currently in the works, we have a presentation guide on CRS and ICANS management that we'll be recording and have that available for nurse training, as this has been identified as a common knowledge gap. Particularly for Tecvayli and Talvey, education is especially vital, since that's part of the REMS requirements to be able to start patients on either one of those therapies at our clinics. As far as actual management of the side effects, we have a CRS and ICANS guide that's available to our clinics that helps with grading toxicity and determining what treatments are appropriate, whether it's like Tylenol for fever or dexamethasone, tocilizumab. As Dr. Birhiray said, CRS is one thing that we're always looking for, especially towards the beginning of cellular therapy starts. And looking for symptoms like fever, low blood pressure, chills, GI upset. There's a slew of different symptoms that can happen, but management is mostly focused on supportive care and reducing that inflammation with steroids and 6 antagonists, so antagonizing one of them. And then Dr. Birhiray also referred to ICANS, which is the immune effector cell associated neurotoxicity syndrome. And here again, looking more for like confusion, changing consciousness, weakness, other neurologic symptoms. And depending on the grade, this is also managed with just holding the drug, levetiracetam or Keppra prophylaxis, dexamethasone, and tocilizumab can also be used in these cases as well.
Thank you, Cassie. I know American Oncology Network, we are very advanced. As a leader in the community oncology practice, we have a lot of experience already, even though this is considered a new therapy for a lot of cancer treatment patients. I know, Brooke, you have helped to draft the standard operation procedures for American Oncology Network. Would you mind give us some introductions, or maybe let us know what the clinical pharmacist's role. And I know definitely our regional clinical pharmacists play a significant role on as an operational champions to establish the important workflows. And could you touch base on that and give us some introductions? How, if a community oncology want to set up the program, what they can do?
Of course, thanks for that question, Melody. So as Cassie mentioned, our pharmacists have worked very closely with our key providers and nurse leadership, revenue cycle leadership to create our SOPs, not only for CRS and ICANS and other toxicity management, but also for simply the initiation of bispecific T-cell engagers. So we have SOPs in place to help guide clinics through this process. We have clinics all across the country, and each might have a slightly different process for how they take these patients through transitions of care to treat them, at which locations they treat them. So we wanted to create one document that could be used by all of our clinics to help guide them through the different choices that need to be made and the different steps that they need to take to initiate bispecific T-cell engagers at their clinic site. So one thing that we do is we outline the roles and responsibilities of each team member, the role of the nurse manager, nursing staff, pharmacy staff, provider, financial counselors. We outline what steps need to be taken by each team member. We also outline for which drugs REMS is required, and we outline the steps for that REMS training and REMS registration. We also take a close look at the hospital observation or admission recommendations by the manufacturers for each of these drugs. So each of the drugs that has been FDA approved since the approval of teclistamab in 2022 has a different step-up dose schedule with different recommendations for when the patient should be in the hospital versus in the clinic. And so we help introduce clinics to this recommended treatment schedule, perhaps some alternatives that could be used based on their geographic limitations. And then we outline, again, different options regarding keeping tocilizumab on hand, like Cassie mentioned, for the treatment of CRS or ICANS. And we walk them through training and getting in touch with their pharma partners for staff training, how to coordinate transitions of care with the local hospitals. We help with some of those conversations to help bridge that gap. So we really just play a role in coordinating each of the steps that needs to be done and making sure that the clinic staff is ready to go when it comes time to start one of these therapies.
Excellent. Thank you, both of you, Cassie and Brooke. Dr. Birhiray, I want to know, could you give some advice to our listener, especially for those community oncology providers? What recommendations you can give it to us if they would like to start a bispecific therapy at the community? Is there anything they can do?
Oh, absolutely. These are new treatments. They do have unique side effects, but it's not impossible to do this in the community setting. Otherwise, the strategy of referring every patient in the community to an academic center to get their therapy is just not effective, and it's just also not efficient. And a lot of patients will be left behind if that's the strategy that you adopt. So number one, what I recommend to people is that when you decide that you want to start a bispecific or any other form of cellular therapy program, number one, you should educate yourself on the potential adverse reactions and how to manage that. You should engage a team of astute pharmacists like Brooke and Cassie and Melody, to work with you to come up with a standard operating procedure. Once you sort of understand the landscape, then decide within your practice where you will do it. I don't think, especially for most community oncology practices where we go to multiple sites, I don't think you should offer it, at least initially, in multiple sites. I think you should centralize it, and then within your own practice, create the expertise. I recommend that each practice should have a physician champion and an associate physician champion for your bispecifics, and then have a pharmacy or pharmacists that you're working with, and then make sure your nurse practitioners and other advanced providers are also in the loop, as well as the nursing staff. So those are some very basic steps that you must take. And then if you have a hospital partner, make sure the nurses on the hospital floor are well educated on the potential adverse reactions, and that you're also working with people across the hall, which means the hospital, to help you deliver these therapies. Then finally, we have created the CONCERT network, which means Community Oncology Cellular Therapy Network, to try to bring together a group of oncologists who are interested in this so that we all can learn together and share our protocols together. And we've created SOPs that are available to any member of our network. We have established some guidelines for members of our network to use in delivering these therapies and also in initiating these therapies. We plan to have about 2 meetings every year. We've had 2 meetings already in 2023. And in 2024, our first meeting, which is our fall/winter meeting, it's going to be in Indianapolis at the Westin Hotel on Friday, the 23rd of February. That's when we have that CONCERT meeting so that we can learn from each other and then, really teach each other how to deliver these therapies. I encourage anyone who's interested to reach us at our website at www.indiehematology.com and look for CONCERT. And there's no fee associated with any membership or attending the meeting. So those are some of the quote-unquote words of wisdom that I have for my colleagues who are interested in delivering cellular therapies in the community. It's doable. Don't be scared of it. We have to do it.
Wonderful. Wonderful. Thank you very much. I know we run out of our time. Before we conclude today's podcast, I wonder if any of our guests, Brooke, Cassie, or Dr. Birhiray, do you have anything you would like to share as the last word?
I'll say you need a Brooke and a Cassie and a Melody on your team if you want to be successful.
Thank you. Thank you very much. I want to extend our heartfelt thanks to Dr. Birhiray, Cassie, and Brooke for sharing your valuable insight and expertise with us. We are truly grateful for your time and knowledge. And I'd like to thank our audience for listening. This podcast is brought to you by Pharmacy Operations at the American Oncology Network. You can listen to all the podcast recordings on our website at www.aoncology.com. We hope you enjoyed this episode, and I look forward to seeing you at the next one. Thank you.
Thank you.
All right. I think